Welcome to our podcast, Psychiatric Services, From Pages to Practice. In this podcast, we highlight new research or columns published this month in the journal Psychiatric Services. I'm Lisa Dixon, editor of Psychiatric Services, and I'm here with podcast editor and my co-host, Josh Berezin. Hi, Josh.
Hi, Lisa.
Today, we're going to take an inside look at three articles. First, ECT use among people who are privately insured in the U.S. Second, we're going to look at an evaluation, a randomized trial of peer-led self-management of general medical conditions for patients with serious mental illness. And finally, we're going to talk about an article that examines racial, ethnic, and gender disparities in healthcare access and use among U.S. adults with serious psychological distress. Let's get started.
All right. So first up, we have Samuel Wilkinson, Edeanya Agbisi.
Well done.
Thank you. Douglas Leslie and Robert Rosenheck on identifying recipients of electroconvulsive therapy data from privately insured Americans. So I don't think we've talked about ECT on the podcast yet.
No, we haven't. And it's an important topic because it's a controversial treatment. It's effective. Lots of data that's effective. But there's also complaints and some... if you Google ECT and memory loss, you'll see that some people complain of permanent memory loss.
Yeah, so I'm sure there's quite a few forums on that on the internet. But when you say it's effective, the data that we have shows a 50 to 70% response rate for treatment-resistant depression versus something more around 16 to 17% for other modalities.
Yeah. So the idea that you have a 50% to 70% response rate for treatment-resistant depression really suggests that it overcomes this treatment, which is really essentially imposed seizures, overcomes the treatment resistance.
Right. And so on one hand, you would think that it would be this widely used and implemented modality, but it doesn't really seem like that.
No.
The data that we have shows that only about 1 in 10 hospitals with an inpatient psychiatric unit have ECT available.
So even have it available,
right.
No less being used.
Right.
Right? So
And
that means 9 of 10 hospitals don't even have it.
Right. And we don't even know how widely used it is in the U.S. either. The last estimates of this are from 1999. Mm-hmm. So this study is actually asking what the rate is of ECT, particularly in bipolar or depressed patients, in the sample that's derived from private insurance records.
Yeah, so this study uses a de-identified insurance claims database called the Market Scan Commercial Claims and Encounters Database. And they used the 2014 database.
So basically, this has CPT codes, it has prescription information, it has ICD-9 diagnoses. Whenever somebody's getting ECT, it's billed in a particular code, 90870, for those of you who are keeping track. And this is a huge sample. So this is more than 47 million people in the database as a whole.
47 million?
Right, that's huge.
Yes.
And about 969,000 of them have a mood disorder, meaning bipolar or major depressive disorder.
So that constitutes our sample.
Right, exactly. And they're also looking to see how people who get ECT are different from those who don't get ECT. So to do that, they use a multivariate regression looking at total psychotropic prescriptions, psychotherapy use, comorbidities, plus age and region of the country as well.
So overall, the purpose of the study was to determine the rate of use of ECT among depressed patients and factors that differentiated those who got ECT from those who didn't.
Right. So in terms of the actual just rate of use, of the 969,000 people in this private insurance database, about 2,500 had at least one ECT treatment. 2,500
out of 969,000.
Right. And so that's kind of the big headline here, that ECT is not very widely used. The population estimate that they get from that is about 5.56 per 100,000. And just to give some context, the rate of ECT in Poland, for example, is 1.1 per 100,000. In Sweden, it's 42 per 100,000.
Yeah. So we're on the low side relative to at least those two other countries.
Right. And so the second point of their study is to look at how the people who got ECT are different from the people who didn't. People who had a comorbid psychiatric diagnosis have about 7 times the odds of getting ECT. older age, substance use, getting psychotherapy, and having above the mean number of medication refills also increase the odds.
So suggesting that the people who got ECT were at the more severe, more needy, and
more comorbid.
Yeah, that people with a more difficult course, which I think is what you would expect for ECT.
Right. The other thing that was interesting is that people in the West part of the country had lower odds of receiving ECT. And this is driven mostly by one particular state that I don't think they were allowed to mention by name, but that has very restrictive policies surrounding ECT.
Mm-hmm. So what do we learn from this? I think we see that ECT rates, at least in this population in 2014, were pretty low. And while we don't have exactly comparable data from earlier periods, to the extent we do have earlier data, clearly the rate of use of ECT has gone down. So, for example, there was a sample in New England in 1995 that found 42 per 100,000 in terms of the use of ECT. So from 42 down to 5.56.
Right. And so I guess the question is, where do we go from here as a field where we have a highly effective treatment that's controversial and that we're not using very often?
Mm-hmm. Yeah, this is a tough study to think about and reflect on what should come next. But I think what comes to my mind, and the authors also mention this, is that it is disturbing that a treatment which really may be the only thing that can help people with the most severe and actually life-threatening forms of depression, that this treatment may not be available to them. And clearly, in the choice of any treatment, the individuals and their families need to be apprised of the risks and benefits. I just worry that some people are missing out on a treatment that could really help them.
Yeah, but the controversy over this isn't going anywhere anytime soon.
Right. So it needs a full airing, it needs discussion, but at the same time, we don't want to lose people.
Right.
To depression.
Next up, we have Benjamin Druss.
He is a column editor of Psych Services. Integrated Care column.
Well, a good place to start. And he has a lot of co-authors here, including Manasvini Singh, Silke von Essenwein, Gretel Glick, Stephanie Tapscott, Sherry Jenkins Tucker, Kathy Lally, and Evelina Sterling.
Wonderful. I want all our listeners to know that I insist on reading the names of all of the authors, and Josh doesn't like to do that. I think that anybody who contributes to a paper should have their name acknowledged on our podcast, although I understand that there are limits.
It's not that I don't like it or that I don't think people should get credit. I just want to keep our listeners, interested. And in the interest of that, we will move on with describing their actual study on peer-led self-management of general medical conditions for patients with serious mental illnesses, a randomized trial.
And this is a great study.
Yes. So, an issue that we have talked about before on the podcast, just the burden of comorbid medical illnesses in the SMI population. This comes up all the time, both in the journal, but also I think in everybody's practices. And I think it's becoming clear that doctors are not going to be enough to solve this problem, partially because most of the management of the chronic illnesses that affect our populations, that management happens not in the doctor's office, right? Like managing diabetes doesn't happen in the hour that you're at the doctor's. It happens in the month in between those sessions.
Mm-hmm. I mean, there's a lot more reasons why MDs aren't enough, but we'll just let it stop there.
Yeah,
we have a multidisciplinary approach to care, and we need to. That I think we're going to do the best, and our folks and patients are going to do the best when we bring all tools to bear.
Right. So this is a multi-site randomized control trial of a 6-session peer program called HARP, which stands for Health and Recovery Peer Program. So this is built on a chronic disease self-management program.
Yeah, which this CDSMP, as it's called, is pretty well known and well established.
Yeah, and it emphasizes modeling healthy behaviors, problem solving, specific disease management techniques, and also development of specific action plans.
Yeah, it's really on the front lines, helping people with their day-to-day lives.
And the authors adapted this program for this particular population and also to be delivered by peers. So they developed groups that are 6 to 10 people led by 2 peers. And they also had one-on-one peer coaching meetings for people who were involved in
between the group meetings.
Right. And the outcome that they were looking at is self-reported physical and mental health quality of life at baseline, then 3 months and 6 months using the SF-36, which is a widely used quality of life scale.
It's well validated.
Right. And so this study occurred at 3 community mental health centers where they recruited and randomized 400 people with both mental illness and comorbid medical illnesses. And those are kind of like the usual suspects of comorbid medical issues. So they randomized them either to this HARP intervention or to treatment as usual.
Right. Yeah. So it's important to note that the control condition or the comparison condition was treatment as usual. There was no attention control or any other real effort to control for aspects of the intervention.
So no groups, no peers, right? And then they also looked at some secondary measures to see, look at the hypothesized mechanisms of how the group might, the intervention may have affected things. So they're looking at patient activation, diet, medication adherence, recovery scale, and also looking at access to medical care as well.
So what did they find?
So you've been eager to get to the results.
Yeah.
Here we go. So people went to the sessions is one thing that they found. 70% went to 4 sessions, 2/3 went to 5 sessions, and 55% went to all 6 sessions. The meat of their findings are that there were small but statistically significant improvements on both the mental health quality of life and also physical health quality of life over the entire treatment interval.
Which is impressive and remarkable.
Why do you say that?
Well, it's hard to get any sustained benefit from some of these group psychotherapies and support interventions. And so, again, to have used a relatively light touch to get this kind of benefit, I think is impressive.
Yeah. And we should also point out that even though the actual number increases on the scales may have been on the small side, those can make a big difference in people's lives.
Yeah, so just to get technical, the improvements in both of their primary hypotheses or their primary outcomes had a small effect size. But according to the authors, even a small effect size on these scales can actually be clinically meaningful. In
a big way, can actually affect things like mortality, 7-year mortality rates, things like that. We should also mention that on their secondary measures, they did find an improvement on the recovery scale in the HARP group that was greater than the improvement in the treatment as usual group as well.
Yeah, and I think one of the reasons that they chose to use a recovery scale was that they thought that the use of peers and the delivery of the program by peers might have an impact on the participants' sense of their own recovery.
And that's really one of the unique aspects of the study is this inclusion of peers in this this wellness group model.
Yeah, and in terms of the study, there's concerns. It's not a perfect study. No study's perfect. It has been, as the authors point out, the outcome measures are all self-reported. So we're not seeing necessarily objective findings or differences in health status.
Right, their A1C didn't go down or
they
something
didn't look
like
at
that.
it.
Right. So they may have, but we don't know yet.
Right. And so, it would be wonderful to see that this kind of interventions has that kind of a benefit. But that will have to follow in the next studies.
All right, stay tuned. So last up we have Judith Weissman, David Russell, Melanie Jay, and Dolores Malaspina on racial, ethnic, and gender disparities in healthcare access and use among U.S. adults with serious psychological distress. So we know that there are huge healthcare disparities in the United States, and this particular paper is looking at this concept of serious psychological distress and looking to see if those disparities exist within people who are experiencing serious psychological distress. So
Yeah, and they're looking at disparities in healthcare access and utilization.
that's right. Just to give people some context about, I hadn't really heard that much about serious psychological distress. It's not a DSM diagnosis, but it's an important concept. So I think that actually the easiest way to get a sense of what it is to look at the instrument that they use to measure it, and it's called the K6. The K6 asks people whether they've been so sad that nothing could cheer them up, their nervousness, restlessness, and fidgeting, hopelessness, whether everything is an effort, and a sense of worthlessness. So the actual scale is rated from 0 to 4 on each of those items over the past 30 days. And if you have a score of more than 13, it's indicative of serious psychological distress.
It sounds right. Nervous, nothing can cheer me up, everything is an effort.
Yes, that would be distressing.
And we've all experienced it.
Yeah. So the data set they're using is the National Health Interview Survey, the NHIS, from 2006 to 2015. And they're looking particularly at a subsample of adults age 18 to 64. And like you mentioned, they're looking mostly at utilization and access. So they're looking to see people's insurance status, whether they're privately, publicly, or uninsured, whether or not they have money to pay for health care, how many doctor visits they have in a year, if they have to change their healthcare provider because of an insurance issue, if they're seeing a mental health care provider.
And the survey, the NHIS survey, will ask questions about all of these things.
That's right. So they're pulling all this data from the NHIS. And then they're looking to see how these differ within white, African American, Hispanic, and other races and ethnicities. Also throwing in federal poverty level and region as well. So they look at 8,940 adults with serious psychological distress as defined by this scale. And that's representative of about 10 million people in the United States. We were talking about how we can kind of best summarize the findings of this paper because it's complicated. There's complex interactions between the concepts. This is one of those that we really encourage you to read the study and dig in because we're not going to be able to do it justice, particularly with an issue that is so complicated as racial, ethnic, and gender disparities in the U.S. healthcare system. That's a huge topic.
So we're going to stick with just the multivariate findings.
The multivariate, and we're going to pull two of them that we think are particularly important. So the first, women, when compared to men, have an increased risk of having insufficient money for medications, for healthcare, and for mental health care. They also have an increased risk of delays in care, of having visited a doctor more than 10 times in a year, and also having to change their place of care due to insurance. Other disparity that we wanted to point out was that whites, as compared with African Americans, have an increased risk of having insufficient money for medical care and mental health care, and also an increased risk of delays in health care, and are more likely to have seen a mental health provider in the last 12 months. So lots of other findings here in the study as well, but those really popped out at us.
Yeah, and so the second finding, the finding about whites in comparison to African Americans, is important because it reverses what we expect to see in disparities with respect to race, with whites tending to have better access and better health care than blacks, as the previous literature has reported, and this reverses that.
Yeah, and it's also in the context, I remember just in the news, these reports about decreased longevity for white men and women. And so, it's a question of there's a relationship between that decreased longevity and just access to care that people are having.
Yeah, and so this finding is not completely potentially disconnected from other things that we're seeing in the public health.
Right.
And the article talks about how blacks have greater access to Medicaid. And of course, this study was done around the time of ACA and Medicaid expansion. But it's possible that having that access to Medicaid can really be an advantage.
Mm-hmm. And then the other question that comes up in using survey data is how people are answering questions.
Mm-hmm. Exactly. So one has to always look at, well, what could be causing this finding to be invalid?
Mm-hmm.
And so, I mean, and in every study, there's a million reasons that you can question the validity of the study. But a question that one would have to ask is whether generally if blacks are answering the questions with the same set of assumptions and frame than are whites, and are blacks systematically, for example, underreporting their difficulty with access and utilization. So again, we don't have the answers to those questions, but the study itself does raise those questions. I mean, how can we understand these findings?
Mm-hmm. And also, as we encourage you to dive in more, the study also tries to make a few comments about how, as you mentioned, the ACA may have affected some of these healthcare disparities in terms of access and utilization, and also how the Great Recession in 2008 and 2009, mm-hmm. those were both smack in the middle of their study design, how those may have affected utilization and access for people with serious psychological distress.
Yeah. And I think I wanted to close by underlining the importance of the gender disparity. Mm-hmm. I think even in the paper it was kind of under-discussed, and I think that it really is that when we're considering disparities, we really need to look across the potential disparity categories and think about how it is and why it is that women may have these barriers, and then how to overcome them. So that concludes our podcast for today. We invite you to visit our website, ps.psychiatryonline.org, to read the articles we discussed in this episode, as well as other great research. We also welcome your feedback. We're always trying harder to make this more interesting. Please email us at psjournal@psych.org. I'm Lisa Dixon.
I'm Josh Berezin.
Thank you so much for listening. We'll talk to you next time.
Bye-bye.